and welcome to episode 2 of From Paper to Clinic. I'm your host, Dr. Hamza Shah, and today we're joined by Dr. Raman Bhakhri. Dr. Bakri is currently a professor at the Illinois College of Optometry, where he teaches ocular pharmacology and retinal courses. He lectures on these topics at local, state, and national meetings. He's a fellow of the Optometric Retina Society, a fellow of the American Academy of Optometry, and a diplomat of the American Board of Optometry. He's also the editor-in-chief of the AAO's case report journal, Clinical Insights in Eye Care. I have had the pleasure of knowing Dr. Bakri for many years now. He has truly dedicated his career to providing excellent patient care and to educating the next generation of optometrists. It's my honor to have him as a guest. Dr. Bakri, thank you so much for joining in today.
Hamza, thanks for those kind words and good to see you again, man.
Thanks a lot. The article we are using for our discussion today is called "Is Geographic Atrophy a Peripheral Retinal Disease?" by Lucien V. Del Priore. Dr. Bakri, can you tell us a little bit about how this article is connecting geographic atrophy and peripheral retinal degeneration?
Sure thing, Hamza. It's a very interesting article. So the premise is that, hey, maybe that a peripheral RPE is involved somehow with the development of macular GA. So the idea starts with, yeah, you get macular GA, which is, again, due to high oxidative stress and whatnot. But then why does it progress? The thought is that there might not be enough RPE cells migrating from that peripheral retina to compensate for the macular loss of RPE. So it's basically like a funnel or a supply of RPE cells that are just stopping or not coming to that macula like they should to replenish and stop that progression. So that's the idea right there, and that's the premise behind the paper.
Yeah, and they mentioned that analogy with limbal stem cells that I really liked. Looking at the cornea, we have our limbal stem cells, and if there's ever a deficiency in your limbal stem cells, we end up developing corneal issues. And some of those corneal issues almost look like some of the issues we end up having in the back of the eye with macular degeneration. We get corneal scarring, corneal neovascularization, corneal defects, and then, you're getting choroidal neovascularization, RPE defects, and then atrophy. So I thought that was a nice analogy.
And you bring up a great point. It's almost analogous, right? Without those limbal stem cells, all of our corneal stuff just doesn't heal up, right? So you need a supply of healthy stem cells or RPE cells. So whether it's a corneal thing or a retinal thing, the idea is basically the same thing. And that's what the authors, I think, were trying to get at.
hmm And while I was reading this, I feel like I'm a little victim to this, but whenever I see some peripheral degeneration, i.e. be drusen, reticular degeneration, or just patches of atrophy, I'll document it, but I don't really pay too much, like I don't give it too much significance. And after reading this, maybe we should look at the macula a little bit more closely, or in patients who are already have geographic atrophy or macular degeneration, we ought to look at that macula with a little bit more significance.
No, 100% agree. I was in the same boat, and again, I think I should be more conscientious of it going forward. Is if you have macular changes going on already, and then they concur or adjacent to peripheral changes, maybe those are patients you watch maybe a little bit fast or sooner, because again, there might be some links according to this paper.
Right. And this paper mentions several studies to back up this claim, right? One of the studies was actually done on rats, and I thought that was quite interesting, where they made focal laser photocoagulation different areas of the retina and saw do RPE cells wake up and start proliferating.
Yeah. So yeah, you
And
saw that
so,
proliferation, which I thought was cool. But like you had mentioned, it was on mice, right? So how much of that can carry over to humans?
right.
You never know, right? But I mean, it does bring up good learning points and pearls.
I'm glad you mentioned that because one thing, retina or mice don't have a macula, or rats don't have a macula, which I think brings up to the second question: were there any limitations in this publication? I don't like rat studies with macular degeneration just because of that fact. Were there any other limitations that you came across?
Sure, I think a lot of it is again theoretical. I think one of the points or studies they looked at was basically the amount of blood flow that's getting to the eye and getting to the peripheral retina. And a lot of that's based off of neurological work. Again, can you apply that clinically? It's hard to because none of these were, a
hmm
lot of this was retrospective, right? None of this was double blind, randomized. It wasn't,
hmm
there weren't proper trials, right? A lot of this was retrospective stuff that they're looking at. So theoretically, fantastic stuff, right? But it's all
hmm
indirect. So how can you actually, correlate it to clinical stuff? You really can at this point. So
hmm
again, biologically, what's the right word? Plausible, but weak clinical proof at this point.
Absolutely. No, I agree with you. I think it's a good thought process. It did, get the gears moving and made me think about the peripheral retina, but how much can we translate this to the clinic? Maybe not a lot, but maybe look at the periphery a little bit closely, try to translate the peripheral findings to patients' macular findings anecdotally, but I think future studies will hopefully give us more insight.
Yeah.
Um, were there any other evidence lacking here? Anything else you want to mention?
No, I think a good, again,
Hmm.
it's fantastic theoretical stuff, but when you look
Hmm.
at it, it just doesn't apply to humans at this point. But again,
Hmm.
exciting stuff, more research is needed, but I feel like that's basically the disclaimer that any research study has is we need to do more research.
Well, you're right. You're right. If the peripheral retina is truly directly related to in protecting the macula from geographic atrophy, what are some proposed new therapeutic strategies beyond just the complement pathway inhibiting drugs?
Sure. So we have the GA drugs, which are fantastic. And again, we can talk about that a little bit later. But the
Hmm.
premise or the idea is of, well, hey, if our peripheral RP is involved, what if we stimulate that peripheral RPE? So whether that's with stem cell activation, maybe you get the RP cells to start dividing a little bit more so or creating new ones, whether it's improving blood flow, like I'd mentioned, if you can improve the blood flow to the peripheral retina, does that make those RP cells more viable? If they're more viable, do they again proliferate or move on down to the macula to fill in those gaps from the GA? Maybe it's a drug that enhances RP migration that's independent of ocular blood flow, right? Maybe you
Hmm.
can stimulate it somehow. And then the last thought would be maybe like a growth factor, right? Can you stimulate peripheral RP cells to again basically just proliferate and then again mosey on down to the macula? And if there's any GA that's starting to set in or just beginning to set in, can these RP cells basically fill in the gap, right? So the idea would be to stop death and basically restore supply. The supply would be those peripheral RP cells. Can we, again, keep on replenishing them more and more and more with these, again, ideas for drugs? But again, the key word here is ideas. There's nothing concrete
Hmm.
out there.
Yeah, there really isn't anything concrete. And one thing I was thinking about is, I'm a big preventive medicine thought. I love the idea of preventive medicine, right? So
Yeah.
AREDS2 is something we already currently have. And whenever patients hit that intermediate stage, or sometimes even earlier than that, I'll go ahead and tell them start taking your AREDS2. And I was like, what if we had another supplement? And I came across AREDS3, which was released recently, with the vitamin B complex. And I personally did a superficial search right after that, and this was a couple days ago. I think it was released a couple months ago. And it does look like vitamin B complex, vitamin B tends to help patients with macular degeneration. This was a superficial search. I think more studies are definitely needed. But have you heard of IRIS 3? What are your thoughts?
I'm probably in the same boat as you, right?
Yeah.
I think it got released. I kind of think it got brushed under or overlooked. You don't hear much about
Yeah.
it from the ophthalmology end about
Hmm.
obviously it's high dose antioxidants, but supplementing with the B vitamins. Is there a benefit? Again, from your thoughts, superficially, again, yeah, maybe it is, but I'm also in the same boat that we should be preventative rather than reactionary, right? So or reactive in terms of our approach. So if there's things that we can do early on, whether it's IREDS 2, 3, UV protection, diet, exercise, right? We should be doing everything we can at this point to prevent those drusenoid changes, GA, wet AMD,
Hmm.
right? Anything we can do before we hit those stages where some of the stuff is even needed.
Absolutely. Absolutely. So moving away from the article a little bit, let's just talk about geographic atrophy, just diagnosing and management and your approach. What testing do you prefer when you see, your patients with geographic atrophy? How often do you follow up with them?
Sure. So, I mean, you start off with your standard stuff like your history and your fundus exam, but you'd be surprised at how much GA you miss on the fundus exam. It's really
Hmm.
hard to see, especially if you don't have your light bright enough, which a lot of us don't because we don't want to, just blast the macula with light. So,
Hmm.
I think my two best tools, and probably everyone's two best tools, would be fundus autofluorescence and OCT. All right. Fundus autofluorescence, I mean, it's almost as simple as black and white, right? And so if you
Hmm.
see black, that's GA. Whether it's a small piece of black on the FAF or it's large, right? You can obviously grade it and then classify in terms of size. If it's white or on the border, then you start to think to yourself, hey, it's progressing too, right? And that's
Hmm.
also something really worrisome at that point. So FAF is fantastic. It's really easy. I mean, all you have to do is have the patient just take a photo, and it's so easy to
Hmm.
explain to the patient as well, right? OCT is fantastic too. I like to, I mean, there's different OCTs you can use, just use your spectralis, whatever it might be. But in the
Hmm.
end, they show you the amount of GA that's present at the fovea, whether it's a small amount like an iRora or a C-RORA.
Hmm.
There's more to it, right? The harder part, I think, to explain to patients is what they're actually looking at with the OCT. I use a
Sure.
cake analysis. Like the top
Mm.
of the cake says happy birthday. If we cut that cake or sliced it, you see the layers of the cake. This is me doing the same thing. These are the layers of the retina. When I make that analogy, they go, oh, yeah, I get it. But you always wonder, do you really get it? And that's why I think the fundus autofluorescence is maybe a better educational tool. So, yeah, those are usually my two go-to drugs, my go-to technologies that I use.
It's funny. I use the same cake analogy. I must have got it from you
It must be
while
funny.
we were in school. I always
Must
tell
be
them,
funny.
I always tell them, whenever we have fundus autofluorescence, we're looking at the top of the cake, and then now here are the layers of the cake. Same, and I agree with you. Fundus autofluorescence, I feel like it's in optometry and even ophthalmology. I feel like it's a underutilized tool. It's such a fantastic tool for GA patients because you're right. Fundoscopically, I'll look at it and I'm like, okay, there's a small area of atrophy. And
Yep.
then when I do FAF, I'm like, whoa, I missed all of that. That's
Yeah.
surprising.
It's fantastic. And then I'll take it a step further. Obviously, there's different types of FAF cameras, the macular ones. I tend
Sure.
to use both, like a macular FAF for more detailed stuff, but ultra wide field autofluorescence is also fantastic. And that might correlate back to what we had started discussing earlier, is looking for those peripheral changes, right? So if you're doing just a
Mhm.
macular fundus autofluorescence, you're missing all that stuff in the periphery. So I'd
Absolutely.
advocate for ultra wide fundus autofluorescence as well, whether that's with optos or any other technology, just getting a bigger picture or a better view.
That is a really good point. Looking at and this whole article is about how important the periphery can be, and I think we'll miss all of that if we're not using the ultra-wide photos.
Yeah.
Moving on to the next question, what are your thoughts on the newer medications, Syfovre and Izervay, for treatment of geographic atrophy?
Promising, right? Promising. So we have a C3 inhibitor with Syfovre. We have the C5
Hmm.
with Izervay. Both are great, anywhere between 20 to 30% in terms of stopping progression. And that's the key
Hmm.
word. It doesn't bring vision back, right? So the special talk you have to have with your patient is like, hey, I'm going to give you a drug. I know you see this right now. The goal is to keep you at this. And if they've already had some sort of vision loss at that point, they don't even know if they're getting better because they're not
Hmm.
gaining acuity per se, right? And so that's obviously a tough discussion. And then the second part, or the flip side, is they're going to be get these injections indefinitely, right? Anywhere from
Hmm.
every month to every other month. And if you're telling your patient it's not getting worse, it's not getting worse, you have to show them concrete evidence, whether that's with FAF or OCT. Like, look, it's working. It's not progressing as fast as it could be or should be, or it's not progressing at all. That's the hard part that you have to start to get towards the patient, is signing them up basically a lifetime and promising a drug that doesn't necessarily restore vision, it just stops progression. That's the hard thing.
I think you're right. And, some of these patients are already getting injected for wet AMD. So
Yeah.
now you've got every 4 weeks they're getting a wet AMD injection, and now they're getting one of the GA drugs. And I think that becomes quite difficult, not only on them, but the family as well, because a lot of these patients have really poor vision. They're not driving. They usually have a caretaker that's bringing them in. And I think that's sometimes a really difficult discussion.
It is the burden of getting all this treatment. You have to weigh that before you make these decisions. Can
Hmm.
I come in every month or every other month? Is there someone to drive me there? Is it something I really want to do at whatever stage of life I'm in? Maybe I already lost vision from a prior CNVM or whatnot, right? And I'm
Hmm.
content with the vision that I have, and I don't want to come in for injections. Again, these are all tough conversations that we have to have with our patients, but I think we have the luxury of, as ODs, where we establish these relationships with these patients, and we can spend as much time as we need to discuss the pros and cons of injecting or not injecting, and then we can relay that to our ophthalmology colleagues. Like, I had this discussion, they're maybe on board, try to see what you want to do. But again, that's the beauty of our profession, is we can spend that time, quality time, with our patients.
Absolutely. And the last thing about that was, there's still an increased chance of them becoming wet if they're not already have wet AMD.
It
So,
is, yeah.
and I always tell patients, hey, at least we have treatment for wet AMD. If you, God forbid, do turn wet, we have treatment for that. But we ought to slow down your geographic atrophy because those patients end up having the worst visual prognosis.
Absolutely, yeah. One of the side effects of both the medications was the formation of CNVMs, even if you had
Hmm.
GA. And I basically correlated to if you have more viable retina, that you have more viable retina to get a CNVM.
Mm,
Not every patient's going to get that. The frequency of that getting that's pretty slim. But like you had mentioned, Hamza, because these guys are coming in like every month, every other month, they're probably getting OCT at the same time. So if you're picking up the CNVM, you're picking it up pretty soon, and then boom, they'll start injecting that unfortunate CNVM that formed right away as well. So it's a thing that can pop up. It's like you said, we can take care of it if need be.
absolutely. So this is a good question to end on. Once the patient's already being treated by a retinal specialist for geographic atrophy, they're already being seen by them quite often. What role can an OD still play in this?
I think it's continuity of care, right? You're still that focal point between the patient and the ophthalmologist. We're spending that time, like I'd mentioned. There's that one eye that's getting injected. Maybe it's both, but what if it's the
Mm,
one eye? We're still responsible for monitoring the other eye, right? We know that if you're getting GA in one eye, there's a high chance you can get in the other eye, right? So if we are seeing that GA is forming or starting to progress, maybe we mention the patient like, hey, we picked this up. This is another conversation that we have to have, right? We're still going over their systemic risk factors, right? Their hypertension, their diabetes, anything that's linked to AMD. We're still talking about diet and UV protection, right? We're having those conversations again that we have the luxury of having with our patients.
And a lot of these patients end up needing low vision assistance. And I think as optometrists, I think we can really fill that void for them.
100%. I mean, that's a niche that's pretty specific to, again,
Hmm.
optometry. Going back to
Hmm.
time, I mean, our low vision doctors are, they spend as much time that's needed with our patients with GA and whatnot, right? And low vision is basically a specialty that we excel in because of that. And so if there's GA, if there's CNVMs and the drugs are working slash not working, right? What are we left with? I mean, I won't say left with, but what else do we have? It's low vision, right? And that's always been there and that's never going to go away.
Absolutely. Well, this completes episode 2 of From Paper to Clinic. Dr. Bakri, thank you again for joining us and sharing such great insights. To our viewers, I hope today's discussion encourages you to look at macular degeneration and the peripheral retina in another light. Episode 3 will air in the first week of May, featuring Dr. Michael Twa, and we will be talking about AI and eye care. Thank you for listening, and I hope you'll join us next time.